Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing US healthcare system. Well, guys, today I have another estradiol video for you. And to be perfectly honest, I don't love making estradiol videos, but this is an issue that continues to come up. Guys have so many questions about estradiol, and as more men get placed on TRT, I feel like there's like a new crop of guys coming in that are just learning about this stuff. And I think it's extremely important that we educate those guys. And sadly, on the forums and in my own private practice and in the practice of a lot of my colleagues that I talk with on a regular basis, we get guys coming from other clinics that are being put on an anastrozole or DIM, or they're being, they're being given information about estradiol that we know is incorrect. Anytime I come across a paper or a series of papers that I think might be of interest to you guys in this area, I'm going to try to make a video about it because I'm just going to keep hammering away at this issue. It still surprises me how many patients get put on gas. And, there's something going on in the education of physicians in the TRT space that really, really needs to be remedied. And, I don't mean to be too harsh on these other providers because, I used to prescribe AIs when I very first got into this space many years ago. We were told to prescribe AIs to keep estradiol essentially within the normal range. Not really realizing that those normal lab ranges they just don't apply to men on TRT. And if we did keep men in those ranges, then they're going to have all of these quote high E2 symptoms, high estradiol symptoms. So water retention, ED, gynecomastia, God forbid, and all kinds of other symptoms. And the truth is that it's really none of that is true. And what we were doing, in fact, was taking away one of the most beneficial aspects of TRT, which is the estradiol conversion from testosterone. It confers many of the benefits that you experience on TRT come from estradiol. And oftentimes, if you're going to have a therapeutic testosterone level, meaning a level that resolves your symptoms, makes you feel and function at your best, and improves as many health parameters as possible. If you're going to have a level like that, many times that will be above the reference range, perhaps not in all cases, but many men get symptom resolution, especially if they're much older, above the reference range. So guess what? Your estradiol as a male, it comes from the aromatization of testosterone in the local tissues. Maybe we'll talk about that a little bit. So it makes sense that if your serum testosterone levels are above the quote reference range, which I have videos on why reference ranges are really junk science. You can check those out. But if you're going to have a therapeutic testosterone level that is above the reference range, newsflash, your serum estradiol level is also going to be above the reference range in most cases, maybe not all. It's going to depend, and we'll talk about that a little bit. So now, I don't want to go down the other rabbit hole that I've got in other videos. You can look those up. Measuring serum estradiol levels is clinically useless in the vast majority of cases. All right, there's always exceptions. But the fact is that estradiol is made within the cell, and it acts within the cell that makes it, and within the local cell cluster that meaning the adjacent cells. It's a paracrine hormone, okay? So whatever is in the serum does not necessarily reflect what's in the tissues. We've done studies now that show that what's in the serum in one set of tissues might be fairly similar, but then in different tissues throughout the body, they're totally different. So when you start monkeying around and manipulating your serum estradiol levels, like you do with an anastrozole, looking for some sort of effect, you have no idea. If you drop your estradiol from 50 to 20 in the blood, you have no idea what that level is in the actual tissues where it matters. Could be wildly off. Could be way, way too low. So anyway, not to go down that rabbit hole. The papers I want to show you guys today are related to estradiol and the development of cardiovascular disease in men, which is something near and dear to my heart, something that I put a lot of emphasis on in my patients, and that I think, honestly, you should as well. Why? Because cardiovascular disease is the #1 killer worldwide of both men and women by a long shot. Second is cancer. So, if you are going to a men's health or a longevity clinic and they're not aggressively, and I mean aggressively, treating you or evaluating you for the #1 thing that could be actually shortening your lifespan and impairing your longevity, which is cardiovascular disease, you're probably in the wrong place, okay? So the the foundation of any longevity program, in my opinion, is the health of the cardiovascular system. You've got to address that. And guess what? Estradiol is a major, major contributor to cardiovascular health. Major contributor. So let's get into the studies here a little bit. All right, this is the first one I want to show you guys, and I've had this in my archives for a little bit, and I just not gotten around to talking about it. But this is from the journal Atherosclerosis. It's like the premier journal that publishes studies on the development and treatment of atherosclerosis. So super good journal, very, very good reputation. It's from 2022, so it's fairly new. So it's entitled Low Endogenous Estradiol Levels, so low levels, are associated with elevated risk of cardiovascular disease mortality in young and middle-aged men in the United States. So we're looking at a group of young men. So in this one, where did they get this data? I think, was it NHANES? Yeah, one of the NHANES, one of the like large population-based data sets that are out there. So they had 954 men. Now, these guys were all healthy, so they corrected for lipid levels and blood pressure and diabetes and obesity. They also controlled for testosterone levels. So that's important as we talk about this a little bit. So average age, 35.7. And then when they enrolled in the study, they checked their serum estradiol levels. And then they followed these guys, I think it was like 1988 to 2015. And they just tracked, they tracked a number of different health parameters, but they looked at, how many of these guys developed cardiovascular disease or died or had cardiovascular disease mortality. And it's pretty interesting. So here is the graph. I'll put it up here for you guys. So here's like the 4 quartiles here. So, quartile 1, 2, 3, and 4, they're color coded for you. So just looking at this, so we have on the left, on the y-axis, cumulative incidence of cardiovascular disease mortality. So not surprisingly, right, as time went on, people start dropping off, right? So the mortality goes up as these guys get older. Now, on the x-axis, obviously, is their age. So, not knowing what this is measuring, like, which group would you want to be in, right? Like, nobody's going to sign up for the red group. Nobody's signing up for the red group. I want to be down in the purple group. But guess what? When you sign up for an AI, guess which group you're putting yourself in terms of estradiol levels, right? A lot of you guys are in this red group, okay? I'm in the purple group, My patients are in the purple group. Let's look at what these levels actually represent. I had to do a little math because I have them in picomoles per liter, and I like to use picograms per ml. Maybe you guys do as well. So in the red group, average serum estradiol level, 30, okay? 30 picograms per ml. Pretty solidly normal level, right? So most people wouldn't get excited about that. We'll just go down to the purple group, 0.7. So look at the difference in mortality. As these guys went out to let's just go to age 80, okay? Huge difference, a huge difference by the time these guys reached 80 years old between the group that had a level greater than 44.07 picograms per ml and the group that was 30 picograms per ml or less. Okay, so huge, huge difference. And that's not a big serum difference, right? It's not a big serum difference. And this gets back to the fact that, again, these serum levels, they don't represent what's going on in the tissues. The levels in the tissue, particularly in the blood vessels, the arteries, in the endothelium where atherosclerosis takes its hold, could be way, way different than what we're seeing in the serum. You just don't know, right? You just don't know. So again, that's why these serum estradiol levels, if your doctor is like routinely checking your serum estradiol levels and like, oh, I just got to get you dialed in, man. If I could just get your AI dose, if I could just tweak it just a little bit to get that number down. Those guys, they don't know what they're doing. You're not dealing with somebody who understands physiology properly and endocrinology. Sorry. Just to give you an idea, this is the Quest normal range for sensitive estradiol, ultra sensitive, which is what you should be getting. You need to be getting a ultra sensitive serum estradiol level. If your doctor's just checking a regular estradiol or like a total estradiol level, for you as a male, that's totally useless. But look, Quest says normal is up to 29 picograms per ml. I know LabCorp and a few of the others, have slightly higher reference ranges in it. So it might, your individual lab may vary. But, for Quest, if you're at 30, you're high. right? You see a little red next to that number, and then you get anxious, and you worry you're going to get gynecomastia, and then you go and your doctor puts you on an AI, right? So, again, I'm going to ask you, which one of these mortality curves do you want to be on? I want to be on the purple one, but a lot of guys, their doctors are taking them from the purple line and they're putting them onto the red line, okay? And they're doing that with an AI. Now, I fully recognize you guys, that love your AIs. These guys are not on testosterone therapy, okay? So we're not comparing apples to apples here exactly. We're doing apples to oranges essentially. But it shouldn't be lost on you the major difference in cardiovascular disease mortality in a group of men that were standardized on all their cardiovascular risk factors and standardized on certain testosterone levels. The major contributor to their differences in mortality in this study was their serum estradiol levels, or over time. So, I show this curve a lot sometimes to my patients, and I just say, like, what curve do you want to be on? What line do you want to be on? And I don't have anybody picking the red one as yet. So super, super interesting. Now, as you guys know, I occasionally share my own labs with you guys. So I'm going to do that with you, mainly because I want you guys to see that I practice what I preach. Okay. So this is one of my more recent lab draws back it was March. Okay. So you can see my serum testosterone levels there. I'm slightly super physiologic. Oh no. But this is where I feel really good. This is kind of where I've been, like, I don't know, probably for the last 10 years plus. It varies, I've been a little higher, but I generally feel pretty good at this number. So I don't monkey around with this. Look at my serum estradiol level, 93.7. 93.7. Now, I'll tell you guys, if you haven't watched this channel before, I take oral estradiol. I deliberately raised that number to 93.7. My baseline is about 27 with similar testosterone numbers. It varies. Like when I get super lean, it's lower. If I get a little fluffy around the holidays, that number can vary a little bit. But I don't check it routinely because I don't care. But it's 93.7 because I take oral estradiol. Now, why do I take oral estradiol? And by the way, just because I do something, I shouldn't have to say this, but just because I do something does not mean you need to be doing this. Okay, this is just me. I don't have any of my patients doing this. This is just me. So why do I do this? Let me show you. So the fact is, if you know my other videos, I've got coronary artery disease. So probably not very much, but I had a positive calcium score at age 50. And in my family, the men die very, very early from heart disease. The reason for that is not because we're diabetic, overweight. My dad's generation, those guys smoked, but everybody smoked back then. And it's not because we had terrible lipids. My lipids have always been really good, with the exception of, here it is right here. This is my lipoprotein A level in nanomoles per liter. So, and for most of my adult life, since I started looking into this, which was in my 30s, this is kind of where I've been. Like at least to 1 feet. So roughly twice, maybe sometimes a little bit more, sometimes a little less, the upper limits of normal. Watch some videos on Lp(a) if you don't know what it is. Highly, highly atherogenic ApoB containing particle, major risk factor for early coronary disease, for stroke, thrombosis. It's bad news. It's completely genetic. Okay, there's very few things you can do to lower this from a lifestyle point of view. There's just like very minor changes, with diet. They're of no consequence. There are very few medications out there that lower it. We used to think niacin would be helpful, and niacin does make this number go down, but niacin doesn't really seem to reduce the number of events, and has a lot of associated toxicity with it. It's a whole nother video. So I was on niacin for a long time. I used to prescribe it quite a bit, like in the early 2000s, but as the niacin studies came out, I've stopped prescribing it. And you'll be hard pressed to find a cardiologist or lipidologist that recommends niacin. The new PCSK9 inhibitors will drop Lp(a). I think it depends on which one you're talking about, but you're looking at like maybe 20% to 30% drop in lipoprotein A. The problem is, or if you don't have insurance, good luck. I mean, in the US, $900 to $1,200 a month, I think is about average. You can see if I'm up to date with that. Maybe it's changed a little bit, but these are super expensive, super expensive. So it turns out there is one other thing. It's actually more than one, but something else that will lower Lp(a). You can probably guess what it is. It's estradiol, right? It's estradiol. This is my Lp(a) here since I started taking oral estradiol. I raised my levels from 27 up to 93.7, okay, 99.5. So I've dropped it about 30%. So on par with what a $1,000 a month medication does, estradiol has given me a similar effect. Now, again, I have no idea. Nobody's ever done the studies, and it probably never will be done. I have no idea if this is sufficient to reduce my risk. I'm assuming it is. I don't know. I'm not. I'm on a statin. I'm on a ezetimibe. I'm doing everything from a diet, nutrition, and lifestyle standpoint that I can. But I've lowered it 30% by being on estradiol. And you know what? I have yet to experience what you guys say are high E2 symptoms. I feel fantastic. I'm relatively lean. Okay, my libido is excellent. I don't have any problems in the bedroom. My mood is good. I have no water retention whatsoever. I'm lean and vascular as always. In fact, I felt better with a higher estradiol level. So, if estradiol is this poison that you guys are so afraid of, like why am I feeling actually subjectively better with such a high level? Maybe all the stuff we've learned about estradiol isn't actually true. And if you have a robust testosterone level, you can tolerate these high E2 levels and derive benefit without any of the potential side effects. Okay, so we can talk about that, maybe more in another video. But again, just because I do something doesn't mean you do it. But I just want to show you that I practice what I preach. All right, let's move on a little bit. Here's another study. So the first one, they looked at the levels for guys when they were young. Well, this is one from the Annals of Internal Medicine that looked at an older population of men. And, guess what, guys? Like the same thing. We're seeing this over and over and over again. We're seeing reduced cardiovascular disease, reduced events, reduced mortality in men based off of their serum estradiol levels at baseline. And this is a chart from that paper. And again, they divide them into quartiles. And you can see as the estradiol level goes up, okay, the hazard ratio, it's a mathematical way of defining risk. Look, it just goes down. It goes down. These men have less events. They have less cardiovascular disease. They're not hospitalized. They don't die at the same rates as men that have the lower testosterone levels. And again, I'll tell you, these guys are not on TRT, so it's not precisely the kind of study that I would want, but we probably never will get the kind of study that I want. But this is important because these two studies I've showed you are just two of like many. I had to pick out, I couldn't review all of them for you, but there are references in the back of both of these papers that show exactly the same thing, that higher estradiol levels in men are associated with less cardiovascular disease in general. You can always find some outlier studies that say exactly the opposite, but if you look at the bulk of the data, this is what you see. This is what you see, higher estradiol levels, even independent of testosterone levels. So I know what you guys are saying. Well, they have higher estradiol levels because they have higher testosterone levels, and of course, higher testosterone levels at baseline in men, of course, are associated with a lot of other positive health markers, etc. And I totally get that, and I don't disagree with that. However, they control for that. It's the estradiol. The estradiol appears to be what's conveying the benefit to these guys. So yet another study. All right. Now, why do higher estradiol levels potentially improve cardiovascular disease outcomes and risk? There's a whole lot of different ideas behind that. One of them is related to endothelial dysfunction, okay? And I have some videos on atherosclerosis, but one of the very first things that happen in the process of making an atherosclerotic plaque, before the ApoB containing particles, overstay their welcome in the endothelium, and before there's oxidation and inflammation, etc., you have endothelial dysfunction. So something damages the endothelium and allows that disease to take its foothold. Okay. Well, one of the major things that you can do to protect your endothelium and to maintain endothelial health is to maintain a healthy, robust estradiol level. And this is a paper that talks about it from 2010 in Journal of Endocrinology. Endogenous estrogen levels are associated with endothelial function in males, independent of lipid levels. So what did they do here? They measured something called flow-mediated dilation, and they did CIMT, intimal media thickness studies on the carotid arteries, and basically plotted out how these men did based on their serum estradiol levels. So if you want to know what flow-mediated dilation is, here's a little diagram here. So they put a blood pressure cuff on you, they take a little ultrasound, and they measure the brachial artery diameter. They pump it up so that like no blood flow is getting there distally. And so what does that do? That causes the endothelium to start like releasing nitric oxide, which allows like dilation of the blood vessel. And one of the hallmarks of good, healthy endothelium or endothelial tissue is to be able to release nitric oxide and to be able to relax and dilate and then go back down to normal size. A healthy artery is a very pliable and rubbery artery. If you have a stiff, calcified artery, that's a sign of endothelial dysfunction and oftentimes, fairly significant atherosclerosis. This is what they found. So here's the chart. So again, as estradiol levels go up, flow-mediated dilation improves. Look at that. In fact, this guy out here, the guy that performed the best, was like 10 or between 10 and 12, had a serum estradiol level, looks like around 50, maybe somewhere between 50 and 55. Most of them clustered here around the middle. They had estradiol levels, somewhere between like 15 and 25. But as the level went up, guess what? Like the amount of nitric oxide that they secreted and therefore the health and pliability and malleability of their arteries improved. So it stands to reason, guys, if you want to keep your arteries young and healthy and you want to keep high nitric oxide levels, guess what? You need estradiol for that. And by the way, guess which organ in your body requires healthy amounts of nitric oxide and requires the ability to for its blood vessels to both contract and expand on demand? Guess what organ that is? I don't think I need to tell you. You need estradiol. That's why I'm saying estradiol does not cause erectile dysfunction, guys, especially in the setting of a robust, healthy testosterone levels. It improves erectile function. It doesn't make it worse. It makes it better. And especially if you want it to stay good when you're 40, 50, 60, 70, 80, maybe even 90, all right? If you're lucky to make it that long, guess what? You're going to have to keep those pipes clean. You're going to have to keep them soft. You're going to have to keep them free of plaque. And one of the best ways you can do that is to keep your estradiol levels in a nice, healthy level. And you don't want to be lowering. There's no benefit. There's no benefit to your endothelium. There's no benefit to your cardiovascular disease risk by lowering your estrogen, even a little bit, by lowering it even just a tiny bit. Because I hear you guys say, "Oh, I don't want to crash it. I just want to lower it a little bit." Okay. Well, there's the curve. So you want to move to the left. But just a little bit. You just want to move to the left a little. Okay. As long as you understand what you're doing and what you're getting into, I'm not going to tell you what to do with your own body. If you feel like you need to lower your estradiol level, that's on you and between you and your doctor. But, I'm just here to give you the information. You want to move to the left on this curve? Okay. You want to go up on that color curve with cardiovascular disease? Okay. Just understand, there can be potentially a cost to doing that long term. Maybe it's not a cost that you're going to pay tomorrow or next year, but maybe 10 years from now, it could become an issue. So let's move on here. Oh, by the way, I didn't mention this, but they have repeated this exact study. They've repeated this study with these guys, and they gave them an AI. They gave them an Astrozole. And what do you think happened to their flow-mediated dilation? What do you think? It says here, boom. In this study, the administration of an Astrozole, an aromatase inhibitor, which results in decreased endogenous estradiol level, resulted in an impairment of flow-mediated dilation compared to the placebo group. Oh yeah, taking an Astrozole, which I know many guys do, they feel like they have to do it. It impairs flow-mediated dilation, guys. It makes your vessel less pliable. It lowers nitric oxide and potentially puts you at higher risk for cardiovascular complication. Again, maybe not next year if you're young, but what about 10 years from now? What about 20 years from now? So I encourage you guys, you have to take a long-term view with your health. I know it's difficult for some people to do. There's people that can't think more than a week in advance, but you really need to start looking at like 10, 20, 30, 40 years down the road. And the decisions that you make, what you put in your body today, and the way that you manipulate your hormones today, it's going to impact you down the road. Take that long-term view. All right. Final paper that I'll talk with you guys about. The other way that estradiol may be impacting the development of cardiovascular disease in that first paper is through its effects on insulin resistance. For those of you guys who, you don't For my carnivore guys out there that don't believe that LDL or ApoB has anything to do with atherosclerosis and it's all about insulin sensitivity, okay, this one is for you. So this is an original article published in the Journal of Endocrinology and Metabolism. Aromatase inhibition reduces insulin sensitivity in healthy men. So what did they do here? They took these young healthy men, controlled for all their cardiovascular risk factors, and they dropped their E2 just a little bit, just like you guys do, right? Just dropped it a little bit. So they took it from 28 picograms per ml to 16 picograms per ml. So like not too different maybe than what some clinics are doing. There's ones that have you guys on like 0.25 of anastrozole, maybe once or twice a week. Maybe this is the kind of drop that that you're experiencing in your serum. Major change in insulin sensitivity in these guys. And guess what? It didn't get better, it got worse. Worse insulin sensitivity. One of the worst things you can do as a type 2 diabetic or pre-diabetic, and you get put on testosterone, is to also take an AI. According to this study and many others, you will make your insulin sensitivity worse. Just by even these small drops in estradiol actually have a significant effect. And why is that? And again, this gets back to the fact that these small changes in the serum do not reflect what's going on in the tissue. We have no idea at the tissue, like at the level of the adipocyte and the muscle tissue and all the other tissues in the body that take in glucose. We do not know what 0.25 of anastrozole twice a week is doing at those local tissues. My feeling is that it's probably significantly dropping it, like way more than what you're seeing in the serum. Because we're going from 28 to 16. That's not that much. What's happening in the tissues? You have no idea what's happening in the tissues. None. And your doctor doesn't either. So they're using serum levels. It's like they're just shooting in the dark. All right, guys. So a couple other ways maybe that estradiol might be affecting cardiovascular disease. Talked about the insulin sensitivity, the flow-mediated dilation, so the early endothelial dysfunction that allows atherosclerosis to take shape. We know that it stabilizes plaque. So once you have plaque, then it actually can influence the natural history of that plaque. It can stabilize it, can give you a thicker fibrous cap. So when a plaque ruptures, when that thin friable plaque that covers the atheroma, when it ruptures, right, that's what leads to a big clot and heart attack, and you come see me and I have to activate the cath lab for you, which I do on a daily basis these days, sometimes multiple times a day lately. So it will help stabilize that plaque as time goes on. We know that it lowers inflammation, right? Inflammation is a significant accelerant and component of the development of atherosclerosis. All right. Again, for you carnivore guys that, don't worry about LDL, but you want to get your inflammation under control. Estradiol will lower high sensitivity CRP, it lowers IL-6, it lowers a whole bunch of other pro-inflammatory markers that are out there. So again, like why are we lowering this? If you have these quote high E2 symptoms, perhaps there are alternative ways to manage those that don't involve lowering or taking away one of the most beneficial aspects of testosterone replacement therapy, which is estradiol. Okay, so that's all I have for you guys today. I hope you enjoyed this. I know it might trigger a few of you guys out there that really, really wedded to your anastrozole. You know what? That's okay. Listen, if you want to take anastrozole, you just keep taking anastrozole. The purpose of this channel and the whole reason I'm here is to inform you guys. Okay, I just want you to make decisions that are right for you. And the only way you can make those kind of decisions is if you have all the information, right? You need to know the good and the bad. And you know what? And then at the end of the day, ultimately, it's up to you. It's between you and your doctor what you decide to do. I know for me, I don't block estradiol. I'm very happy with my estradiol levels. I want to live a long, healthy life. I don't want to have an MI like many of the men in my family have had in their 50s. I'm in my 50s now as well. So I want to keep the good times rolling. And the best way that I can do that is to keep my estradiol levels nice and high. That's where I like them. All right, guys. Leave me some comments. Tell me what you think. Even if you hate what I just said, that's fine. I don't mind hearing alternative points of view. I don't ban people in the comments, unless you're just like rude and unprofessional, which really like nobody in my audience does that. You guys are all great. So I will catch you next time. Bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.